Good morning, everyone, and welcome to our third news conference, our second one just this morning here at ENDO 2018. My name is Aaron Lohr. I'm the Chief Communications Officer at the Endocrine Society, and I'll be your moderator today. And it is my pleasure to welcome you to our news conference on diet. Joining us today are four wonderful presenters. We have with us Dr. Theodore C. Friedman. He's the Chairman of the Department of Internal Medicine and Endowed Professor of Cardiometabolic Medicine at the Charles R. Drew University of Medicine and Science in Los Angeles, California. We have Dr. Daniela Jacobowitz, Professor of Medicine at Tel Aviv University in Tel Aviv, Israel. We have Dr. Sabi Sen, Associate Professor of Medicine at George Washington University in Washington, D.C., and Dr. Thais Razia Silva, postdoctoral student at the Universidade Federal do Rio Grande do Sul in Porto Alegre, Brazil. And over the next 25 minutes, you'll hear each of their presentations, and you're going to be very eager to ask them questions because you're going to love what you're hearing. But I want to remind you that the questions are going to be saved until the very end. So after every presenter is gone, they're all going to sit back down. Then I'll come back up and say, now is the time that we open the floor to questions, and you're welcome to do so. But I do have one very important ground rule. Because this event is being live webcast, it's important that every remark that's being made is made into a microphone, because if we don't, the people that are on the webcast will just see our mouths moving and they won't know what's being said. So that means our presenters will be speaking into this microphone. During the question and answer session, we'll be passing around a handheld microphone, and we ask you to raise your hand when you have a question. We'll pass the microphone to you. You can say who you are and who you're with and ask your question, and these mics will be turned on and we can answer those questions right from the head table. Okay, enough with the rules. Let's get on with the news conference, and I'll invite my first presenter, Dr. Friedman, to come on up to the podium.
Thank you, everybody, for coming today, and thank Aaron for his hospitality and the Endocrine Society for the great work they do. I'm going to be talking today about e-cigarettes in the Western diet, important metabolic risk factors for fatty liver disease, and I'm at Charles Drew University in Los Angeles. E-cigarettes contain nicotine, which we and other researchers have reported is associated with non-alcoholic fatty liver disease. However, the long-term effects of e-cigarettes on liver disease, diabetes, heart disease, and stroke are unknown. E-cigarettes are growing dramatically, and e-cigarettes use exceed conventional cigarette use among adolescents and is likely to exceed conventional cigarette use among everybody within the next 5 years. And many regulatory agencies and also consumers assume that e-cigarettes are safe, and in spite of them containing nicotine, which has both cardiovascular and metabolic effects. And on the left is a young adolescent who is blowing his e-cigarette smoke. Nothing that unusual about that, except he happens to be my son, who I try to lecture him about how evil e-cigarettes are. Yeah, teenagers are teenagers. So what we did is we developed a chamber to give e-cigarettes to mice. And part of it is it's very hard to study e-cigarettes in people. People use regular cigarettes as well as e-cigarettes. You certainly couldn't do some kind of prospective study on e-cigarettes in people. So we ended up making this chamber in mice, and it's programmable. It allows different episodes of the e-cigarettes. The e-cigarettes are given at night when the animal's awake, when the mouse is awake. And during the day, the mouse goes back to the vivarium and sleeps. And you can see here in the mice are inside the chamber here. This is the chamber without the smoke in it. Here's the chamber with the vapor in it. The vapor comes out of these holes here. And we use blue e-cigarettes, which is the most popular brand of e-cigarettes in the United States. They get put in here and they get programmed. And in this study, we used mice missing the gene for apolipoprotein E, and this makes them more susceptible to heart disease and liver disease. And I think it's important, although this is a model, it's not to say that a normal mouse wouldn't develop this as well, but this allows us to pull out the effects more easily. The mice were fed a diet relatively high in fat and cholesterol. One group of mice was put into a chamber that exposed them to e-cigarette aerosol so that their blood nicotine levels were similar to that of smokers and e-cigarette users. A second group of mice were exposed to saline aerosol, and we also did some experiments with e-cigarettes that did not contain nicotine, just to show it's not the e-cigarette itself that's causing the problem, it's really the e-cigarettes plus the nicotine. And you can see here that on the left is the saline exposed animals, on the right is the e-cigarette exposed. This is their livers. It's different types of staining. And you can see that the liver is full of fat. Those white droplets over here are all the fat. and you can see at electron microscopy level, it's a huge amount of fat in the liver, and you can also see the nucleus is affected. The nucleuses are smaller. It's called apoptosis. It means the cells are breaking down. Basically, this looks like a sick liver. We then we collected the liver samples and looked at genes in the liver affected by e-cigarettes using a technique called RNA sequence analysis. And we found changes in 433 genes that were associated with fatty liver development and progression in the mice exposed to e-cigarettes. Some of the genes here are related to circadian clock genes. Circadian clock genes are what are the genes that tell the body to wake up in the morning and go to bed at night. And it's been shown that the alterations in some of these circadian clock genes has an important role to play in fatty liver disease. And we found that the e-cigarettes affect some of these genes pretty dramatically. In summary, the popularity of e-cigarettes has been rapidly increasing, in part because of advertisements that they are safer than conventional cigarettes. But because the extra fat in the liver that we found in the mice exposed to the e-cigarettes, I don't think it's reasonable to conclude that e-cigarettes are safe. And I think this should be promoted to consumers. Consumers maybe are these young people that could be using e-cigarettes for many decades of their life. They should know some of the risk associated with them, and the regulatory agencies such as the FDA need to take this into account when they're coming up with rules governing the e-cigarettes. The question you're going to ask me, probably the question, but I'll already sort of give you my thought on it, is does this happen in people? I think it's very hard to test in people. As you said, that people are smoking regular cigarettes, e-cigarettes. You can't biopsy their livers readily. My guess is it does, but you have to study a lot of people. This is not everybody that's going to be using e-cigarettes are going to get this liver, but a significant number of people are. That over the course of the millions of people that are using e-cigarettes, this is going to be quite detrimental. So I conclude that e-cigarettes are not as safe as they are marketed. And I want to thank our funding from the DDAR program, from the Access program, and for the California Tobacco-Related Disease Research Program. We got also the core activities at UCLA Genomic Core and at CDU Access help perform some of the RNA sequence analysis. Thank you so much.
Thank you, Dr. Friedman. Our next presenter is Dr. Daniela Jakubowicz.
Okay, thank you very much. I will refer mainly to the effect of meal timing and frequency. I will show how big breakfast diet have influence and is a good strategy for weight loss and glycemic control with less therapy of insulin. As you know, I have many years in endocrinology, more than 25 years, and I realize since many years that those people who eat more in the evening get weight more easy than those who design the more quantity of calories to the morning. After that, I have seen, and our own study have shown that the glucose response after identical meal, for example, a slice of bread, increase significantly more the glucose when it is eaten in the evening compared to the morning. After that, there were many other studies that show that this is not just observation, that there is a lot of science behind. Now we know that our body has a master clock that is responsive to the light, and the peripheral clocks that are responsive to the meal timing. So the meal timing has a pivotal influence on the circadian clock genes, especially in the liver, in the heart, in the gut, and the adipose tissue. And these clocks regulate several changes that are named circadian change. As you can see here, but under the influence of the circadian clock genes, the cortisol and adrenaline goes up, and the growth hormone goes up at night. The cortisol is up in the morning. Means that our body does not work similar in the morning than in the evening. As consequence, we make several studies. We have shown that the breakfast diet with higher amount of calories in the morning versus dinner diet is more effective to weight loss, for reduction of hemoglobin A1C, for overall glucose and postprandial glucose across the day in obese and type 2 diabetic patients treated with oral anti-glycemic, anti-diabetic medication. So the problem now in this study that the study involves participants who are diabetics but treated with insulin. So we have additional problem because the overweight patients with type 2 diabetes and insulin resistant or overweight often require high insulin doses. But this insulin makes them fat, make them gain weight more easy. So weight gain worsens the insulin resistance and glycemic control, requiring further increase of insulin that again increase the weight, and this is like vicious cycle that this patient have in the treatment, and the vicious cycle with continuous weight gain, with persistent hyperglycemia, and high risk for complication. We have seen a lot of studies about meal timing, and there is a direct correlation between frequency and type 2 diabetes, obesity, and overall glycemia. Compared with the 3-meal schedule with high energy breakfast. So we in this study compared these two schedules with 6 meals versus 3 meals with high energy breakfast, and we observed that the glycemic control was much better in the 3 meal. The 3 meal was more effective to weight loss. They lose almost 12 pounds in comparison to 6 meals. They lose almost nothing, and actually some increase the weight. The waist circumference was lower, the fasting and overall meal glycemia was better also, and there was significant reduction of the insulin dose in those patients who followed the 3-meal diet. Interestingly, there was a decrease on hunger and carb craving in the 3-meal diet. In conclusion, the time when you eat is more important than what you eat. This is my team. One part of Tel Aviv University, the diabetes unit at the Wolfson Medical Center, and the other part in the Hebrew University of Jerusalem. And thank you very much.
Thank you, Dr. Jakubowicz. Our third presenter today is going to be Dr. Sen.
I would like to thank the organizers, Aaron, for inviting our work and me to present data on an artificial sweetener, most commonly the sucralose. So, as an introduction, as you know, artificial sweeteners or low-calorie sweeteners are increasing in use every day. And however, there are a lot of animal model studies which have actually alluded to the fact that these may be detrimental in subjects who are actually the main takers, which are the metabolic syndrome and diabetes patients. However, we wanted to actually do a systematic study where we look at fat-derived stem cells and how does these agents affect those, looking at their gene expression and adipogenesis and inflammation, and also look at the human subjects' fat who have actually taken these agents over a period of time. So these are various studies that has actually showed that there are side effects of sweeteners which are of concern. Not only they are, as they were touted before, that they are inert sub-agents, doesn't seem to be the case. Our group from NIH has actually showed that it's absorbed from the gut and secreted back into the bodily fluid, such as breast milk. So here is the schema of the mesenchymal stromal cells, which, as all of you may know, is a multipotent cell. And under various environmental conditions or media conditions are shown to differentiate into fat, bone, and cartilage. So we wanted to see first, in vitro, how does the sucralose in a graded dose affects the differentiation of these cells. So, and as you can see, there are various transcription factors which control this differentiation over a period of time. So we went ahead and looked at various concentrations, so that just not one concentration has been looked at, 0, 0.2, 0.45, and 1. Of which 0.2 would be very close to what you would achieve in a serum of a patient who habitually takes the sweeteners. And we actually went ahead and did albedo staining to show the fat composition. So here are the fat-derived stem cells, and as you can see, certain genes that I showed in the slide before, but let me go through it. The cholesterol ester binding protein, fatty acid binding protein, these are the glucose transporters, taste receptors, all seem to upregulate in a statistical significant fashion over the concentration gradient. Not only that, if you actually stain these cells over a period of time in a media that would actually promote adipogenesis, but if you add sucralose, it actually promotes even faster. We actually looked at various genes, and it seems that certain antioxidants, and this was actually surprising, and we actually questioned why this is happening. There are quite a few antioxidants, not only one, but cytosolic, the ones that are in mitochondria, are upregulated again in a dose-dependent fashion. So we actually went ahead and did a stain that's called MitoSOX, or mitochondrial SOX, which actually looks at the reactive oxygen species accumulation. And we not only did a qualitative picture, but also actually looked at the intensity of fluorescence. And again, surprisingly, well, not surprisingly, there was an increase in fluorescence of the cells in a dose-dependent fashion, which have higher concentration. So next, we actually went ahead and looked at the human fat samples. And this is where the most interesting part comes in. We segregated them into two different groups. One, normal weight, and two, obese individuals. And most of their A1C was in a pre-diabetes range. So these are not overt diabetes patients. They were from different racial background. There were only 18 of them. And I do agree that that is not a huge cohort, but looking at the gene expression, you would agree that all the gene expression that we looked at before, like cholesterol ester binding protein, FABP4, antioxidants, in normal BMI patients did not show some trend, but there was no statistical significant difference in between takers and non-takers, takers being in red. But if you look at the same genes in obese individuals, now we see a statistical significant increase, not only in the genes that control fat formation that are upregulated in these individuals, the glucose transporters, which probably are upregulated, indicating that there's more glucose entry. So if there's more glucose in your blood, it's going to flood into the cell, which we also know promotes fat formation. And also, if you look at, again, the antioxidants, again, they're upregulated, which means the cells that we found were trying to fight off the reactive oxygen species. The same genes, almost in a similar fashion, are upregulated in obese individuals. And here, the number of subjects that we had were actually more than the subjects in normal weight, which would indicate a normal US population. So in summary, what I wanted to highlight that sucralose does seem to upregulate adipogenic genes, inflammation, and reactive oxygen species, not only by staining, but also on gene expression. And it's similar pattern of genes that seems to upregulate not only in the dish, but in the subjects who actually took this artificial sweeteners. And it seems to be more detrimental in subjects who these sweeteners are geared for, the obese individuals. So I would like to thank my team. I didn't bring their picture, but my team, my university has been very supportive of me, and thank you to the society. Thank you.
Thank you very much, Dr. Sen. Our final presenter today is Dr. Silva.
Good morning. It's a pleasure to be here in the news conference to present some results about our study from Gynecological Endocrinology Unit in Hospital de Clínicas de Porto Alegre in Brazil. So the title of our work is Mediterranean Dietary Pattern is positively associated with bone mineral density and lean mass in postmenopausal women. This is a cross-sectional study. So it is known that menopause is characterized by decreased estrogen production and has been linked to declines in bone mass, as we can observe in this figure, and increasing the risk of osteoporosis and fractures. Also, menopausal transition have been associated with skeletal muscle mass loss and increases in waist circumference and visceral fat mass in the postmenopausal period. Moreover, the age-related loss of skeletal muscle mass and strength are major contributors to increased mortality, morbidity, and reduced quality of life in older people. In the past years, Mediterranean diet have been related to positive health outcomes and received growing attention. This dietary pattern is characterized by low intake of red meat, as we can observe in this pyramid, low to moderate intake of dairy products, moderately high intake of fish, high intake of fruits, vegetables, seeds, cereals, and olive oil, and also moderate but regular intake of red wine. This dietary pattern has been associated with lower risk for diabetes and cardiovascular disease, but data on body composition are limited. Therefore, the aim of our study was to investigate the association between Mediterranean diet, body composition, and bone mass in a sample of healthy postmenopausal women. Concerning the methods, 105 healthy postmenopausal women from southern Brazil, aged between 45 and 65, were enrolled. Participants with prior diagnosis of heart disease, current smokers, and patients with diabetes were excluded. These women were interviewed and answered questions about their diet in the previous month. They had to inform if 121 food items were included in their diet and the quantity of portions consumed by them. We calculated Mediterranean dietary pattern using a score, which represents a summary value of consumed foods and characterizes a measure of adherence to a Mediterranean type diet. High scores indicate better diet quality. Body composition and bone mass were assessed by dual energy X-ray absorptiometry, and appendicular lean mass, which represents the sum of lean tissue in arms and legs, was scaled to high square to estimate muscle mass. And habitual physical activity was estimated by average number of steps provided by 6 consecutive days of wearing a digital pedometer. Then the results. We observed that a greater adherence to a Mediterranean diet was associated with lower prevalence of low bone mass, which means osteopenia plus osteoporosis, as we can observe in this figure. Regarding skeletal muscle mass, women with higher adherence to Mediterranean diet have higher skeletal muscle mass compared to those with lower Mediterranean diet score. And previous hormone therapy, previous smoking behavior, and physical activity did not influence these results. And postmenopausal women with higher adherence to Mediterranean diet had an average of 5 more years of school. It is pertinent to mention this higher education level because evidence indicates that diet quality may be linked to education and plays an important role in determining food consumption behavior in Brazil and also in other studies in a Mediterranean region. In conclusion, Mediterranean diet was associated with higher bone and muscle mass in the present sample of healthy postmenopausal women from a non-Mediterranean region. While there is some evidence that a Mediterranean diet lowers the risk of osteoporosis, to the best of our knowledge, few studies had been done on the topic of muscle mass. But more studies are necessary to clarify the effect of Mediterranean diet on body composition. In the meantime, the emergent evidence suggests that a Mediterranean diet combined with other healthy lifestyle habits may be a useful non-pharmacological strategy for the primary prevention of osteoporosis and fractures in the postmenopause. Thank you so much for your attention.
Thank you to all of our presenters this morning, and now is the time that many of you have been waiting for. We're going to open the floor for questions. Just a reminder, if you have a question, to please raise your hand, and Jenny here with the microphone will extend it towards you, and you can say your name, who you're with, and ask your question.
Ed Sussman with MedPage Today. For Dr. Jacobowitz, can you sort of describe what a high-energy breakfast would be and a medium lunch and a light dinner?
Basically, in the study, it depends of the patient because we adjust the calories and this to BMI, etc. But basically, the high energy breakfast was between 60 and 70 calories, and the lunch was about 500 calories, and there was small breakfast. And a small dinner, and the lunch was exactly the same as in the 6 meals, only that the dinner was completely different, and the composition was carbohydrates, proteins, and fat. It was a high-caloric breakfast.
Josh Cohen, George Washington University. Dr. Silva, I'm wondering, would you expect that a Mediterranean diet would have a greater amount of phytoestrogen than the non-Mediterranean diets that your patients took, that your study subjects took?
I'm sorry, could you repeat your...
Yes, I'm wondering if you think that, I mean, just as one possible explanation, if there could be more phytoestrogens in the diet, you know, plant-derived estrogens in the diet, in the Mediterranean diet.
I don't know, because estrogen, phytoestrogens source are soja, how can I say? I don't think so. I think it's not the cause of our results. I think that doesn't. My coordinator could answer for you better than me. Sorry.
Thank you for your question. The foods we analyzed have no phytoestrogens or other oils. And in fact, we measure the estrogen levels, but we think we need to increase the sample size to be sure that there is no more estrogen in women that eat a Mediterranean diet. But probably not. For the moment, probably not.
Very interesting.
Hi, Chris and Monica with MedPage Today. My question is also for Dr. Silva. You said that previous hormone replacement therapy used did not affect the outcomes. I was wondering how you controlled for this, and was this surprising to you?
We excluded participants with that are using hormone therapy. So all of our sample didn't use hormone therapy. And in our analysis, we controlled for previous 3 months before enter the study, and did not influence the results. Are similar between with women using or did not use.
Was this surprising to you? Did you expect them to be similar?
Yes, it's surprising because diet could be more effective than hormone therapy. I don't know, but it's surprising. Yes.
Okay, thank you.
Jody Godfrey with Endocrine Web for Dr. Jacobowitz. I too would like to follow up on the question of meal content. I'm curious about whether you actually had some women on diets that were higher in fat versus higher in carbs, and if you did a nutrient analysis so we know whether they had diets that were higher in protein, higher in good fats versus saturated fats, and the variability of their diets.
We in this study we didn't care about this very much. It was a high fat diet, high carbohydrate diet, and high protein diet. There was not restriction of specific composition of the diet. That was restriction of the time. Okay, and actually there are studies that show that high-fat diet at the right hour is beneficial for glucose metabolism. And the same diet with high energy dinner and small breakfast make bad influence on glucose metabolism. So we want to show this. So our breakfast is high in carbohydrates and also is high in proteins because one of the goals of the study is to decrease the hunger and carb craving, and we have previous studies that have shown that if you increase the carbohydrates in the morning and also the proteins, there is a suppression of ghrelin, the hormone of hunger, and is significantly less. The people have less hunger and less carb craving after 4 o'clock in the afternoon. So. We was not trying to decrease the fat or just to maintain the time of breakfast.
Any other questions? If not, our presenters will be up here if you want to spend some time asking them a few questions. And we are done here today. Thank you so much for coming.